Hello, my name is Misty Cotton. I am in the Family Nurse Practitioner program at East Tennessee State University. I will be discussing one of the geriatric syndromes, sleep disturbance. So I want to just go over what exactly a geriatric syndrome is. It is a condition, not a disease, and it is very common in the older adult. It is typically multifactorial and it has been linked to functional decline. It refers to a pattern of symptoms and signs with a single underlying cause that may not yet be known. It has multiple risk factors and multiple organ systems are often involved. It has shared risk factors. The most common geriatric syndromes are delirium, falls, frailty, dizziness, syncope, and urinary incontinence. These are classified as geriatric syndromes. One of the most underdiagnosed geriatric syndromes is sleep disorders among older adults, and this is what I will be discussing in this PowerPoint presentation. So, what is the background and significance of the geriatric syndrome sleep disturbance? The research shows that approximately 50% of older adults complain of difficulty sleeping, which results in an increased risk of significant morbidity and mortality. One study that was published in the Journal of African Sciences in 2017 showed where 203 patients over the age of 75, they were studied and underwent a comprehensive geriatric assessment. 99% of those had at least one chronic disease. So the results of the study showed that older adults accompanying physical diseases may contribute to the development of insomnia and sleep disorders. Chronic pain related to arthritis, cancer, or diabetes, COPD, CHF, and neurological diseases are considered the most relevant diseases in sleep disorders. They result in undesired consequences such as impairment in cognitive function, decreased physical performance. There is a higher risk of falling, traffic accidents, respiratory depression, and even physical dependence. So, the significance for nurse practitioners or other healthcare providers is that we need to be aware, and sleep should be examined in all patients, and it should be a routine part of any comprehensive geriatric assessment. We need to ask, is this sleep apnea or insomnia causing serious negative physical, mental, and social consequences? Obstructive sleep apnea has been associated with hypertension, coronary artery disease, depression, even car accidents, cognitive impairment, stroke, and mortality. Especially depression. Depression and sleep disturbances have been shown to be closely related. So recently, I had a patient that came into the clinic, and the subjective data gathered in her was that she was a 66-year-old female. She had recently been widowed in the year 2016 after being married for 38 years. She is now living alone. She does have one adult child and no grandchildren. She has type 2 diabetes, major depressive disorder, peripheral neuropathy from her diabetes. She has gastroesophageal reflux disease, hyperlipidemia, hypertension, hypothyroidism, obesity, obstructive sleep apnea. Surgical history included a parathyroid resection. All immunizations were current. She was currently taking Celexa, Zantac, atorvastatin, lisinopril HCTZ. She was on multiple medications for her diabetes. She took aspirin a day. She was also on thyroid replacement. She was allergic to pravastatin because she had reported that it caused muscle cramps and muscle aches. So subjective data gathered may include a patient presenting with just vague complaints. They may look disheveled, fatigued, or even poorly groomed. Their facial expressions may be neutral, angry, or sad. They could be uncooperative, or they may be cooperative, asking appropriate questions. They may be answering your questions appropriately, but we always want to assess their level of consciousness to make sure that there aren't any underlying things going on. Common complaints are often poor memory. They report having trouble falling asleep or staying asleep. They report waking up multiple times throughout the night, waking up too early between the hours of 4 and 6 a.m. They have increased falls at home, increased accidents at home, depression, and feelings of anxiety. So findings on a review of system include reports of fatigue, headaches, weight loss or weight gain, obesity. They report excessive daytime sleepiness, as we've discussed. They report snoring, headaches. They have feelings that the oropharynx is narrowing, trouble swallowing. They report respiratory problems such as suddenly waking up in the middle of the night and gasping for air. Cardiovascular reports of palpitations or chest pain. Vague abdominal pains. Also, they may report having to go to the bathroom multiple times at night or any incontinence. They report restless legs, joint or muscle arthralgias. And neurologically, they report brain fogginess, not feeling alert. They have memory changes and depression and anxiety. So back to my patient, some of the objective data gathered on her is that she is 5'2" tall with a weight of 188 pounds with a BMI of 34.39. Blood pressure was elevated at 158/84. Overall physical exam was normal. She did appear ill and fatigued, but overall neurologically everything was intact. Her gait was steady and normal. The Romberg test was negative. We completed a geriatric depression scale on this patient, and her score was 6, and it was suggestive of depression. We also completed a mini mental status exam with a score of 30, which means no cognitive impairment is present. Diagnostics and further workups needed to consider. Start by taking a thorough history. So the history is going to be the most important thing when evaluating a person's sleep habit. And although many sleep-wake disorders are diagnosed through this history alone, some do require further diagnostic tools or formal sleep testing. Examples include keeping a sleep diary or actigraphy for the evaluation of sleep-wake patterns and the diagnosis of circadian sleep-wake rhythm disorders. If you do suspect obstructive sleep apnea, you want to do a home sleep apnea test or refer them to a sleep specialist for a sleep study. When clinically indicated, we need to draw a TSH level to evaluate for hypothyroidism. We need to do a complete blood count to evaluate anemia or polycythemia, which can indicate nocturnal hypoxemia. We also need to check a fasting glucose in obese patients to evaluate for diabetes, and we can also check ferritin levels if they are having reports of restless leg syndrome at night. Rarely, we need to do ABGs to check for daytime hypercapnia. One of the things that we need to consider and further investigate is polypharmacy in older adults. Is any medication disturbing their sleep? And when possible, the culprit medication should be discontinued. Older adults have slower drug metabolism, so we need to consider this. Our treatment goals should be well defined with the patient and their caregiver prior to initiating any type of therapy. Goals vary according to the primary symptom and may include reduced awakenings, increased total sleep time, or improvement in daytime sleepiness. Behavioral non-pharmacological treatments that focus on environmental changes and establishing consistent patterns are the mainstay of therapy. The evidence-based plan to treat sleep disorders in older adults is to actually confirm that the patient has insomnia. You identify the symptom by discussing the onset, duration, pattern, and how severe it is. We're going to evaluate a 24-hour sleep wakefulness pattern. We're going to review 1 to 2 week sleep diary. We're going to interview the bed partner if they have one. We're going to review the family history of sleep disorders. So once we identify the cause, is that cause a primary sleep disorder? Is it a medical illness? Is it a psychiatric or behavioral illness? Are environmental factors affecting their sleep? And also the medications. We're going to evaluate the personal and societal impact that this sleep disorder is having on our patient. Through a comprehensive physical exam, we are going to do appropriate lab investigations. We are going to discuss the expectation of the treatment with the patient. Effective treatment of the primary problem is important. We are going to discuss sleep hygiene measures, non-pharmacological measures, and if needed, what pharmacological interventions are best for the elderly patients. And if necessary, we are going to refer to a sleep specialist. Differential diagnoses include geriatric depression, hypothyroidism, obstructive sleep apnea. So to rule out depression, we start by doing a thorough depression screening, and we can use tools such as the Geriatric Depression Scale. We can rule out hypothyroidism by simply checking a TSH level, a T4 and T3 level. The gold standard test for obstructive sleep apnea is a full night in a laboratory sleep center. So in my patient, the final diagnosis related to the geriatric syndrome was worsening depression and general anxiety disorder. These were causing her sleep disturbance. She is a 66-year-old Caucasian female. She admitted to not following a diabetic diet all that closely. She reported her blood sugars were still elevated. She reported that they were averaging around 140 and 200. And she admitted to not being compliant with a diabetic diet. She didn't exercise. Really just was not taking care of herself. She had complaints of feeling increasingly depressed, and she reported difficulty getting out of the bed in the mornings. She has had a few crying spells and stated that some mornings I don't feel like getting up out of the bed, and I have nausea in the mornings also. She reported waking up multiple times throughout the night and excessive daytime sleepiness. She did try to get her Celexa increased at the VA, but they would not do it. And she complained of waking up nauseated and had been assisting her elderly mother who has dementia. And she was reporting that things were just very difficult in her life at this point. The why of the final diagnosis in my patient was because her depression had significantly worsened since the loss of her husband 2 years prior. And according to the National Institute on Aging, depression is a common problem among older adults, but it is not a normal part of aging. In fact, studies show that most older adults feel satisfied with their lives despite having more illnesses or physical problems. However, important life changes that happen as one gets older may cause feelings of uneasiness, stress, and sadness. SSRIs are considered the first-line treatment of depressive disorders in older adults due to better tolerability, ease of use, and general safety, especially in overdose. Depression is a primary mood disorder characterized by a depressed mood and or a markedly decreased interest or pleasure in normally enjoyable activities most of the day, almost every day for at least 2 weeks, and causing significant distress or impairment in daily functioning with at least 4 other symptoms of depression. Thank you for listening to my presentation on the geriatric syndrome sleep disturbance.